Hi everyone, I am Dr. S. Nagendra Bhupati, working as an Associate Professor of Cardiology at the Department of Cardiology, Sri Ramachandra Institute of Higher Education and Research. Today we will be discussing about percutaneous aortic valve therapy. I would like to thank Dr. Ranjit Karthikeyan and Raaonline for providing this wonderful opportunity. Before going into percutaneous aortic valve therapy, we should know about the disease. So, the disease is severe aortic stenosis. I will be discussing about diagnosing aortic stenosis, what is the natural history of aortic stenosis, and how we can manage aortic stenosis in 2021 and what are the different modalities that are available currently. Etiology, globally it is the degenerative aortic valve disease, that is aging, degeneration of the aortic valve, just like coronary artery disease. The aortic valve definitely gets aged because of wear and tear mechanisms. And this is a normal valve. A normal valve has got 3 leaflets, a right coronary cusp, left coronary cusp and non-coronary cusp. You can see the ostium of the coronaries on both the sides. As we grow older and older because of wear and tear mechanism, because of associated comorbidities like hypertension, the valve gets degenerated, the valve gets thickened, gradually it gets calcified, and there is going to be restriction of movement of this particular leaflets, leading to stenotic calcified aortic stenosis. It affects 2 to 5% of older adults. Statistical modeling has suggested an incidence of something around 4 to 7% per year among patients who are more than 65 years of age. As I told earlier, globally it is the degenerative aortic valve disease that is much more common than rheumatic. If you look at the picture, there are three leaflets here, the left, right and non-coronary cusp. In some individuals, these 3 leaflets may become 2, which we call it as bicuspid aortic valve. There are a lot of classification how we can classify bicuspid aortic valve. To simply say that there is going to be anatomically 2 leaflets or functionally 2 leaflets. This commissure may get fused. If it is going to be fused, which we call it as type 1 bicuspid aortic valve. If 2 commissures are fused, then we call it as type 2 bicuspid aortic valve. If there is going to be only 2 leaflets, then we call it as bicuspid aortic valve, typical bicuspid aortic valve. So, 2/3 of individuals who are having severe aortic stenosis, who are less than 70 years, the leaflets are going to be bicuspid. When I say bicuspid, they can be typical classical 2 cusp bicuspid aortic stenosis or a 3 cusp. However, one commissure is fused, that is RAF. We call the particular fused commissure as a RAFE. There can be a type 1 or type 2 bicuspid aortic valve, as I discussed earlier. Now, going toward more detailed classification of bicuspid aortic valve is beyond the scope of this particular topic. So, to summarize, individuals who are going to be younger, chances to have bicuspid aortic valve is higher. Individuals who are going to be older than 70 years, chances to have bicuspid aortic valve is going to be on the lower side. However, still it is something around 40%. Especially in India, our data says that we are encountering more patients with bicuspid aortic valve anatomy as compared to Western population. When and how to diagnose severe aortic stenosis? Usually, severe aortic stenosis patient presents with dyspnea, which is the most common symptoms. So, most likely because of diastolic dysfunction leading to elevated pulmonary capillary wedge pressure. So, LV is there is an inability of the left ventricle to increase the cardiac output, especially during exercise. This may even lead to fatigue. Syncope can happen in 10% of patients with severe aortic stenosis. What are all the mechanisms of syncope in patients with severe aortic stenosis? Something called as exercise-induced vasodilation. It can happen to me, it can happen to anyone, it can happen to most of us. If we are going to exert a lot, this phenomenon may lead to decrease in cardiac output from the venous return because of excessive amount of sweating. This leads to vasovagal phenomenon. In patients with aortic stenosis, there is going to be significant amount of LV. So, any decrease in cardiac output, any decrease in LV inflow may significantly impact the LV outflow, leading to compromised cardiac output. Already the system is compromised because of calcified aortic valve, that is not letting the blood to go out of the left ventricle. Whenever the inflow is going to decrease, then there is no significant amount of blood that is going to be received by the brain to maintain consciousness. So, this can lead to exercise in such situation may decrease the cardiac inflow to the left ventricle, leading to syncope. A transient bradyarrhythmia can lead to syncope. Why does syncope is common in patients with severe aortic stenosis? As I told earlier, the aortic valve is very closely networked with mitral valve. It is closely networked with, if you look at the picture, if this is going to be, this is the heart what I am drawing, it's a schematic diagram. I am sorry, I am not an artist. So, this is the mitral valve. Let me draw the 4th chamber view what we look at in the echocardiogram. this is the mitral valve, this is the aortic valve. Okay, this is the interventricular septum, this is the left ventricle, this is the cavity. Okay. So, aortic valve is very closely associated with mitral valve here. The conduction system that starts from SA node here all the way goes here and then reaching the AV node, and through his bundle goes into right bundle and left bundle. Left bundle bifurcates into anterior fascicle and posterior fascicle. The his bundle is very closely associated with aortic valve annulus. So, whenever there is going to be a fibrotic phenomenon, calcification in the aortic valve, the calcification in this particular zone can extend into the basically aortic valve is situated here, can extend into this AV node or the his bundle, leading to decrease in conduction velocity of the particular system, and sometimes it can lead to complete heart block also. Naturally, they are more prone to develop bradyarrhythmias. Similarly, they are also more prone to develop abnormal baroreceptor response, and as there is going to be LVH in severe aortic stenosis, these patients can develop any kind of tachyarrhythmia. So, basically these patients with aortic stenosis cannot tolerate a severe exercise, that may lead to decrease in cardiac inflow to the left ventricle, leading to poor cardiac outflow and reduction in blood supply to the brain, leading to syncope. Any kind of arrhythmia, if it is going to be bradyarrhythmia, any tachyarrhythmias, they cannot tolerate, and their baroreceptor response is not great. They can have abnormal responses to baroreceptor mechanisms. Similarly, aortic stenosis patient can have chest pain. Why do those patients with aortic stenosis develop chest pain? This is a normal left ventricle. Left ventricle is here, mitral valve is here, aortic valve is here. In patients with aortic, this is the interventricular septum. Mitral valve, aortic valve. In patients with aortic stenosis, there is going to be significant concentric LVH. We all know coronary perfusion pressure happens that is equal to system diastolic pressure minus LV-EDP, left ventricular end diastolic pressure. Because of significant LVH in the left ventricle, the LV end diastolic pressure is going to be increased. Whenever there is going to be increase in LV end diastolic pressure, if there is no simultaneous increase in diastolic pressure, your coronary pressure is going to fall. So, this is the most important reason why patients with aortic stenosis develop exertional symptoms. They can have exertional symptoms because of associated coronary artery disease. They can have exertional symptoms because of associated other diseases like aortic regurgitation. They can have coronary chest pain because of increased demand that is associated with left ventricle. We all know cardiac muscle needs oxygen, needs blood, needs nutrients. Whenever there is going to be increased demand because of significant amount of left ventricular hypertrophy that has happened because of the aortic stenosis, and decreased supply. Why decreased supply? It can become because of the associated coronary disease, or it can be because of the increased LV-EDP. So, coronary perfusion pressure is dropped. These patients can have chest pain. Having said that, if you look at the history and natural history of these patients, associated CAD is commonly seen, something around 50% of patients, because they are all elderly patients. Most of the risk factors that are associated with coronary disease, they have been proposed as a risk factor was aortic stenosis, that includes dyslipidemia, hypertension, aging, male sex.